Hello, everyone. My name is Maurice Canavaca, and it's my pleasure to co-share this session with my friend, Dr. Andrea Natali. And this is going to be a very exciting session that is focused on the specific aspects of atrial fibrillation and atrial flutter ablation. We have four specialists in these different strategies. They are not so common for the regular electrophysiologists. So I think you're going to have many doubts and questions. And please send us your comments, because we have at least 40 or 20 or 30 minutes after to make our discussions. So Andrea, would you like to make an introduction?
Yes, thank you, Maurizio. Pleasure being here, and thank you for this opportunity. I agree with Maurizio. This is a very exciting session because touch on different aspects that really address some of the latest approach to atrial fibrillation. So I think you should enjoy this. And as Maurizio said, and we encourage you to ask questions if you have any doubt about what you hear. So welcome, and let's go. Let's move on.
Great.
Good afternoon. Again, this is Andrea Natale for the Latin America HRS. And in this presentation, I'll talk about why and how to perform ablation around the left atrial appendage in CS for trigger from this anatomical location. So first, this is my disclosure. First, I want to start with a few cases to show you in what is the typical case scenario. So people think that we do the appendage in everybody, but we don't. Actually, very rarely the first time we ablate somebody, unless it's very obvious, we isolate the appendage. But when patients come back for redo procedure, and there is no reconnection around the pulmonary vein, that clearly becomes a target. So this is one of these patients is a 66-year-old male with sleep apnea, obesity, BMI of 30, persistent AF, that was associated with also with tachycardia-induced cardiomyopathy. They had 3 IF ablation, 2 PVI in 2013, 1 PVI posterior wall in 2015. And then after the last ablation, he had recurrence in a few months. And this is EKG. And this is so he came in sinus. It was kind of persistent. So cardioverter stayed in sinus for a while. So here you see it's in sinus. This is his map. So posterior pulmonary vein and posterior wall is permanently isolated. He has some portion of the posterior wall closer to the along the CS that is not. And then obviously anteriorly, you see the appendage is completely normal. He has some settle lesion that you see there. And this is recording. This is, you can see that the lasso is in one of the veins, it's isolated. And so what we start doing is to finish in the isolation of the posterior wall that you see here. And then we also isolate the appendage. So I want to show you how it's done. So it's in sinus, which is what I advise people to do at the beginning. Do it in sinus, because in sinus, you can do almost a segmental ablation. So you see here the lasso in the appendage, and you see the recording, and you see as we ablate that the appendage activation change. He developed a little bit of tachycardia from the appendage, but all on sustain. We continue the ablation. And I'll show you in a still frame so you can appreciate. So this is the appendage before we started. So you see that the earliest, so usually the position that we put the lasso in the appendage, but we tilted anterior in LAO view, and you see that 6 and 7 is the area. So we ablate there, you see the noise where the earliest is, and this change the activation. Now the earliest is in 9 and 10, so we target 9 and 10, and that kind of, besides causing some PAC, isolated the appendage. Okay, so that in blue you see the location where we achieve isolation. So, and then here you see that after isolation, the patient has dissociated firing during isoproterenol testing. And you see here again the dissociated firing. Then as we give isoproterenol, then the conduction not only return, but actually develop this tachycardia. So the patient is in sinus, develop this tachycardia from the appendage that you see here, but doesn't conduct. So, but then once the ISO, we give a few more burn, and once the ISO is discontinued, then the appendage appear isolated again. So, but then looks what happened on isoproterenol beside the tachycardia from the appendage, which after a few ablation became silent again with dissociated firing. The patient had firing and reinitiation of fibrillation, as you see here, from where? From what you, so here you see sinus, and you see the ablation that is at the ostium of the CS being early. So, and here you see also early, so from the proximal CS. So at that point, we start ablating the coronary sinus, and you see that we already had done the endocardial part with the last, the lesion at the bottom of the posterior wall. So now we do the epicardial, and as we ablate, you see that CS9 and 10 is early, and the tachycardia slow down, and eventually get to this one with a very early CS9 and 10, and eventually stop. So, and you see that the rest of the CS is now silent. So you only see this far field from the ventricle. So another patient is a 57-year-old with hypertension, sleep apnea, multiple AFib ablation, last one 8 months earlier. He comes, was sent to our patient, to our center, and you see that we started the ablation in a sort of AFib, and the pulmonary vein were isolated, so we target the appendage, and as we ablate the appendage, you see that the posterior wall, the rest of the atrium is red, quiet, and as we ablate the appendage, we achieve isolation eventually. You see that the appendage is quiet, and then we start ablating the CS, and then the appendage reconnected. So we keep go back to the appendage, and as we re-isolate the appendage, then the patient goes back in sinus rhythm. So I think you see here the patient now is in sinus rhythm, and I think I'll show you here as the appendage dissociated, and as we ablate at the spot in the appendage, we have termination to sinus rhythm. Then on isoproterenol, the patient developed this tachycardia from the CS. You see here sinus, a PSC, and then here a tachycardia start with very early recording the CS. And remember, we started ablating the CS when the appendage reconnected before the termination. So we go back inside the CS because the endocardial part has been done already. And then as we ablate the epicardial part in the location of the sharp potential, then the tachycardia stop and the patient is in sinus. So I want to show you how we isolate the CS. So usually we have this recording here. So typically, here again show the CS termination during ablation. There is it. You see that as we ablate the CS and the patient goes back in sinus rhythm. So the way we do the CS is the endocardium first, as you see here, and then after we do the epicardium. So, but the first step is to minimize ablation inside the coronary sinus, is to ablate endocardially along the CS until we don't record any more electrogram from the ablation catheter. And here is a kind of a diagram showing the endocardial part along the course of the CS before we do the epicardial part, as you see in the bottom part of the slides. And this is kind of to show you the endpoint. The endpoint is not just any small recording, but really we want to silence SES. So those are the recording before, and this is the recording after, where there is no atrial recording. This you only have this sort of far field V from the CS. So it's not attenuation of the recording, but the complete isolation of the CS. This is what we have seen to be the best outcome And I'll show you some data. So another area that is relevant for as an atrial fibrillation source is the appendage, which we reported in 2010 in a group of patients that had multiple failed procedure where the pulmonary vein were isolated. And in about 27% of those patients, we saw that the appendage was a source of triggers, either because they were sustained or because they were consistent skipping beats. And we realized that from that series that the best endpoint, as for the coronary sinus, is isolation of the appendage, which is shown here. In long-standing persistent, we did a randomized study called BELIEF, where patients with long-standing persistent were randomized to PV posterior wall plus non-PV trigger ablation, including the appendage, but the appendage was isolated only if it led to reinitiation of sustained arrhythmia, which we saw in 9% of the control group, whereas the other group beside the other non-PV trigger, so not just the appendage, beside the other non-PV trigger, also had empirical isolation of the appendage in all the patients. And you see here that with a single procedure, the empirical isolation group in red had a better outcome than the group where the isolation of the appendage was done only in 9% of the patient. Also, I'll show you some data that support isolation of the CS rather than focal ablation when you identify the CS as a source of trigger. This is a paper that was presented as at LAHRS, but now under review, showing patient where the pulmonary vein are already ablated, the CS trigger, and in one group, a focal ablation was performed, in the other group, CS isolation was performed. And you see that a follow-up, the outcome were much better in the CS isolation group than in the focal ablation. This is a Kaplan-Meier showing better those results. So in summary, CS and left atrial appendage isolation are non-PV trigger source or recurrence, predominantly in patients with non-paroxysmal AF. To improve outcome, isolation of both structure is the best endpoint. Thank you very much.
Thank you very much. I will be discussing how to perform veno-marshal ethanol infusion. It is beyond the scope of this talk to discuss the mechanistic underpinnings and the justification of veno-marshal ethanol, but so briefly I will discuss that the veno-marshal sits in the epicardial aspect of the left atrial ridge in a critical site for paying mitral flutter, and it contains abundant innervation that can be profibrillatory in atrial fibrillation. This is the location as you would look at it endocardially. So the most common reason to deliver veno-marshal ethanol is to achieve mitral isthmus ablation, because the current technology for mitral isthmus ablation is inadequate. We achieve bidirectional block in 30 to 60% of the cases, and is determined by variable anatomical factors, the length and thickness of the left atrial ridge, the coronary sinus flow and its cooling that prevents effective radiofrequency ablation lesions from forming, leaving residual conduction via epicardial fibers. And coronary sinus ablation may be required that only addresses the annular epicardium and not the rest of the epicardial aspect, and it has potential risk of less circumflex damage. An anterior mitral line may have better results, but unavoidably leads to conduction delay to the left atrial appendage. And as we will be presenting shortly, we just finished a randomized clinical trial showing that veno-marshal ethanol infusion, when added to conventional pulmonary vein isolation, achieved better results in atrial fibrillation ablation of persistent atrial fibrillation. So, brief overview as to how this is done. This is a whole complete video of how this is done. We first get coronary sinus cannulation from the IJ, my preference, and people prefer the femoral vein. Then we put a Lima, left internal mammary artery catheter, engaged in the coronary sinus looking for the veno-marshal. And in the RAO view, it will become obvious as an atrial branch of the coronary sinus. Then we will put a wire and a balloon in the veno-marshal. We follow the wire with the balloon as distal as possible in the veno-marshal and inject contrast here. You will see some myocardial staining, that is okay. That's where we deliver the first ethanol infusion. Then we retract the balloon, inflate it more proximally, give a second infusion of ethanol. You can see with contrast the outline of the branching of the veno-marshal. Then we retract the balloon, inflate it again more proximally, deliver a third infusion of ethanol to make sure the alcohol goes into these proximal branches. And finally, either a fourth or a fifth injection of ethanol in the most proximal aspect of the vein of Marshall. So this seems to be very quick, but it can be a little bit more problematic than just in this video. I like to use internal jugular access because I am positioned in the same side of the patient for both my work in the femoral vein as well as the work in the vein of Marshall. I bend the coronary sinus sheath so that it's facing me, and I can work pretty comfortably once the CS sheath is engaged in the coronary sinus. Then we put a Lima guide catheter and inject contrast looking for the vein of Marshall, which will be in the roof of the CS in this AP or LAO view, and in the RAO view will be going posterior. We like to try to engage the Lima into the ostium of the vein of Marshall, and that's done like that. And then we inject contrast. Notice that we have inside the Lima the wire with a preloaded balloon here, so ready to go. Then we will advance the angioplasty wire deep into the vein of Marshall, and then we use over-the-wire balloon. Do not use a rapid exchange balloon. It has to be an over-the-wire. Obviously, you're going to give alcohol through the lumen. You advance the over-the-wire balloon over the wire into the vein of Marshall. It's useful to torque the Lima so that it remains engaged in the vein of Marshall. And then once we have the wire in the vein of Marshall, then the balloon is advanced and it follows. We advance the balloon as distal as possible in the vein of Marshall. I like to inject some contrast in the distal vein of Marshall because sometimes you see other branches of atrial veins that could be going in the roof of the left atrium or even extracardiac. We then inflate the balloon anywhere between 4 and 6 atmospheres. I actually use even less lately because the vein is too small and the balloon inflation is not even seen. We deliver 1 cc of ethanol over 2 minutes. We flush the balloon with saline because there's a large dead space in the balloon lumen. Deflate the balloon, retract it about 1 centimeter, reinflate the balloon, deliver another cc of ethanol over 2 minutes, and repeat the sequence. Depending on the length of the vein of Marshall, we could do it up to 4 or 5 or 6 times. But we like to inject that sequential positionings of the balloon, usually about 1 centimeter apart from one another, from distal to proximal. So this is as far as we could get this balloon in this vein of Marshall, and we're delivering the first injection, and then we give contrast. Notice that there's some myocardial staining, and then through collateral, you see contrast coming back to the CS, usually through appendage veins that drain into the coronary sinus. Here we retracted the balloon 1 centimeter and give a second injection. And this is contrast injected after the alcohol has been given. You can see more myocardial staining. Then a third injection with more myocardial staining. And notice now that you don't see the contrast coming back to the CS because usually those capillaries that communicate with collaterals get obliterated with alcohol. We will then, in this case, we only gave 3 because this vein of Marshall was relatively small. I like to do a final CS venogram. We pull the wire and the balloon out of the vein of Marshall and inject contrast through the Lima to verify absence of contrast extravasation in the pericardial space. That's happened to me once or twice, but it's usually of no consequence, although there are reports of significant pericardial effusions in the literature. Myocardial staining around the vein of Marshall region is common and is typically inconsequential. And it actually means that there's going to be a therapeutic effect because the alcohol is going where the contrast is going. And if you see myocardial staining, that means that you have myocardial delivery of ethanol. Then I will do some troubleshooting as to tough cases as to why the vein of Marshall cannulation can be difficult in certain cases. So there are venograms that you do, and then you don't see a vein of Marshall. But if you pay a close attention here, there may be a faint something in this region going vertically. So my recommendation is to make sure you have a posterior torque of the Lima and maybe check in other views because you may see a vein of Marshall in other views. This is one example when just torquing posteriorly, you have a very, very significant and juicy vein of Marshall there, whereas in the previous view, you couldn't see it. if there's some cases where there is a large vein of Marshall that requires this extreme posterior torque of the lima. Remember that the vein of Marshall takes off proximal to the valve of Usance and posterior in the wall of the coronary sinus. There are cases where in a first injection you don't see it, and then you advance more distal, and then you can see a vein. Now, if we're rigorous here about the anatomical nomenclature, probably this vein is not a true vein of Marshall. Probably this is a left atrial appendage vein, which sits in the base of the left atrial appendage and can be a perfectly appropriate target for ethanol infusion. Sometimes you don't see it in RAO in the first injection, like in this venogram. Then you try more proximal, and boom, you have a huge vein of Marshall here. So you have to be careful interpreting these venograms that can be tricky sometimes. I would like to alert you about the multiple anatomical variations that we have found in vein of Marshall. This is one example of what we call plexus vein of Marshall, when you cannulate it and there's too many branches to count, taking venous return from a large portion of the left atrial wall. I'd like to also inform you about the collaterals that can be present in the vein of Marshall. This is one example where injecting contrast, you see opacification of the vein of Marshall, and then we see a collateral to the roof that even drains in the right superior pulmonary vein. Many of those collaterals, once you give alcohol, because alcohol would obliterate these capillaries, then you don't see them anymore when you inject in the vein of Marshall. Does vein of Marshall alcohol always work? It really depends on the capillary network of the vein of Marshall. Remember that the way this works is by myocardial reach. The target here is the myocardium underneath the vein of Marshall, not the vein of Marshall itself. We could argue about the potential role of innervation and argue a lot of things that we cannot prove or disprove. But what matters here is that you want to achieve a therapeutic effect by myocardial reach of alcohol. And if you have vein of Marshall like this one with no capillary branches, you may not get a significant effect. These are examples on top of very, very limited branching and limited capillary networks of vein of Marshall. And in the bottom, we have another 5 examples of vein of Marshall with abundant capillary networks and associated myocardial branches that will lead to a much more pronounced therapeutic effect. We published a large series of anatomical variants of vein of Marshall 3 years ago in JACC-EP. And then, depending on this capillary network, you may have alcohol injections that don't lead to a significant low voltage effect, or at least by conventional criteria. If you change the voltage settings, you may see that there's some decrease in the voltage, but no distinct scar. Whereas in others that have more rich capillary networks, injecting alcohol can lead to a very significant scar. And it also depends on the locations. There's a huge variation in the location. There's cases where the vein of Marshall is very close to the CS ostium, like in the top examples, and there are cases where the vein of Marshall is very far from the CS ostium. If we are to be anatomically correct, the vein of Marshall is one that takes off ostial to the valve of Usance. If you see a vein of Marshall more distal, that's probably not a vein of Marshall, it's probably an atrial vein, could be an appendage vein or others. We described the entire venous vasculature 3 years ago using basically our entire experience of vein of Marshall venograms, showing that sure, you have a vein of Marshall as number 3 here from the ostium, but sometimes there's a septal vein, sometimes there's a posterior vein. There is commonly an appendage vein and then a roof vein. And then there are capillary sinusoids or venous sinusoids that drain directly in one of the pulmonary veins or just communicate from vein to vein. Very similar to what had been described in anatomical specimens by von Ludinghausen years ago. Depending on where the vein of Marshall is or where the injected vein is, you will get a lesion accordingly. So this is one example where there was no vein of Marshall that we could cannulate, but we cannulated the inferior vein. And then we had a proximal annular lesion that went from the annular septum inferiorly towards the right inferior pulmonary vein. The vein of Marshall will give you, alcohol in the vein of Marshall will give you a nice line of scar or low voltage from the mitral annulus to the left inferior pulmonary vein in the posterior mitral isthmus. Some larger inferior branches can give you massive amount of scar. If you inject alcohol in an appendage vein, you will have a scar in the base of the appendage towards the posterior aspect of the appendage. The vein of Marshall, this is another example. And sometimes you can actually inject in the anterior branches and you will get something that resembles an anterior mitral line when you give alcohol. So these are the things I need you to know, that in order to understand the procedure of alcohol injection in the vein of Marshall, there's simply a few steps that you need to understand and you need to take. You need to understand the anatomy and then understand the anatomical variations. And if you have that background knowledge, you will succeed. Thank you very much.
Hello, this is Pasquale Santangeli from the Hospital University of Pennsylvania. This presentation will focus on septal flutters and tachycardias, highlighting how to diagnose them, the mapping features, and the ablation approach. These are my disclosures. Can septal flutter even exist? When we looked at our experience with these challenging tachycardias, which had been eliminated from the right or left interatrial septum, when we are quite puzzled, as the classical anatomical teaching is that there is no true interatrial septum beyond the fossa valis, which is per se a fibrotic structure. However, anatomical studies have consistently shown multiple interatrial muscular connections on the level of the septum, both superior and inferior to the fossa valis region. These, of course, include the Bachmann bundle, but also multiple other myocardial bridges that may represent a substrate for both focal and reentrant arrhythmias. There is positive data regarding the prevalence and features of septal flutters. In this early paper by Nasir Marouche, including 11 patients with organized atrial arrhythmias refractory to antiarrhythmic medications, septal flutter were defined as a planar reentrant circuit that involved the upper and lower muscular limbus of the fossa valis. It is important to emphasize that the authors were able to define the circuits with activation mapping and able also to record the full cycle length of the circuit with surface mapping as well as with entrainment mapping. Our experience at the University of Pennsylvania with septal tachycardias and flutters is different from what we reported in this early paper. This is an example of a case of a 68-year-old patient with recurrent atrial flutter after 2 prior AFL ablation procedures. The coronary sinus activation pattern we have typically encountered in these cases is proximal to distal, with a quite fast activation within the coronary sinus, covering only 10 to 20% of the tachycardia cycle length. The coronary sinus activation pattern is important, but also you can see the high-density activation map typically shows a left atrial or right atrial early septal breakthrough with passive activation of the rest of the left and right atrium. The full cycle length of the tachycardia is not covered with biatrial mapping, nor we were able in this case to visualize any surface atrial circuit or re-entry around the septum. As such, entrainment mapping is quite crucial to define the critical size where to apply radiofrequency energy, because all you can see with activation mapping is an early septal breakthrough, which can be either right-sided or left-sided or simultaneous right and left-sided. Following activation mapping, we always perform detailed entrainment mapping at these sites of earliest breakthrough to define the shortest return cycle. In this case, we were able to identify critical septal sites with an entrance in the left atrial septum at the level of the upper limbus and an exit in the opposite right atrial septum. In these cases, we can imply that the remaining portion of the diastolic pathway is hidden within the septum. However, identification of the critical septal sites with a good return cycle, which in this case was PPI minus CCL was 0, is usually a quite good predictor of successful ablation, as we can typically terminate these flutters with focal radiofrequency at the sites with perfect post-pacing intervals. The importance and definition of the critical sites with entrainment mapping in these cases cannot be overemphasized. It's quite important that the typical workflow is to create a detailed biatrial activation map and then proceed always with entrainment mapping, tagging the sites with best PPI. In this case, you can see that we are mapping a tachycardia with a cycle length of around 30 milliseconds and an early procedural septal breakthrough that is almost simultaneous in the left atrium and in the right atrium. Entrainment mapping determined the shortest PPI in the left side of the septum, which was for under 30 milliseconds on time. However, sequential ablation at that particular site, followed with the opposite side of the septum, only resulted in slowing the tachycardia from 430 to 480 milliseconds without tachycardia termination. Quite similarly, in this other case, and very similar to what we learned for VT mapping, we also seen indirect evidence of atrial flutter involving entirely intramural circuits, like the one here. Here, entrainment mapping also failed to show any site in the mappable left atrial surface and right atrial surface with a return cycle within 30 milliseconds from the tachycardia cycle line. In this case, we chose to apply a sequential radiofrequency ablation first at the septal sites appear, showing their shortest return cycle, and we had no effect on tachycardia at all. In cases like this one and the one before, when we only saw tachycardia slowing with sequential and unipolar radiofrequency application, we have been using bipolar radiofrequency ablation. This is guided by the results of entrainment mapping, and radiofrequency energy is carefully titrated under direct ICE imaging at the selected septal sites. In this case, a bipolar application of 30 to 40 watts, as you can see here, and I'll show the setup later, 30 to 40 watts in flutter, resulting in termination, slowing and termination within 18 seconds. And typically, at this point, we do extend ablation for a full 60 seconds at these sites. Going back to these slides, the bipolar configuration that we've been using has been described by the University of Colorado group of Wendy Zhou and Peter Sauer. We typically use one contact force sensing catheter and another non-contact force sensing open irrigated catheter, as the information from the contact force can only be displayed from one catheter. One of the two catheters, typically the non-contact force sensing, at least in our centers, is chosen as a ground catheter. And as I mentioned, we have been using moderate powers, 30 to 40 watts, while carefully monitoring the impedance trend and as well the ICE imaging, looking for echogenicity, etc. during the ablation. Our fellow, Lohit Garg, has been reviewing our institutional experience with septal flutters and tachycardia, and have to be thankful for this work. We screened 295 consecutive patients undergoing catheter ablation of atrial fibrillation between 214 and 219. 26 of these patients, 9%, were diagnosed ultimately with intra-atrial septal tachycardias. We call it tachycardias instead of flutters because for some of these patients we were not able to define the mechanism, if it was re-entry or focal, because it looked like a focal breakthrough and there was only a few sites like they were located in the septum with perfect post-pacing interval. 14 out of 26 patients, 54%, had a prior AF ablation with a median of 3 procedures in a range of 2 to 5 procedures. In 46% of patients, they had prior cardiac surgery, which included atrial septal defect repair in 5, later left atrial maxillary resection in 1, so the majority had really surgery involving the left atrial septum. And the ECG features in 88% had positive P waves in the lead 2, 3 in ABS for the inferiorly directed, positive P waves in V1 to V3, and typically they transition between V4 and V6 with an isoelectric to negative P waves in V4 and V6 and lead 1 in ABL. Here you can see some examples of the typical ECG patterns encountered in these patients. Again, typically positive P waves in the inferior leads, in the anterior precordial leads with transition in V4, and typically predominant inferiorly directed forces. And here I'll show you the EP features. 77% of these flutters had a proximal to distal CS activation and a mean total cardiac sinus activation times of 77 milliseconds, which is really only covering 10 to 20% of the tachycardia cycle length. All patients had evidence of bipolar intra-atrial septal substrate with low amplitude and fractionated electrograms. Entrainment mapping, as I showed you earlier, is crucial to determine the critical sites where to apply radiofrequency energy. In 27% of cases, we found perfect entrainment at the septal site, but in a large majority of cases, the PPR minus TCL was slightly longer than the tachycardia cycle length within 25 milliseconds, 73% of cases. In the remaining cases were between 25 and 30 milliseconds again. High density biatrial activation map was performed in 10 cases, 38%, and it was unable to visualize the full planar circuit in any patients, and always consistent with intra-atrial septal early breakthrough with passive biatrial activation. And these are the ablation outcomes. Catheter ablation of these flutters was acutely successful in 92% of cases, 24 out of 26 flutters. And this was successful only in the right intra-atrial septum in 2 patients, in the left septum in 8 patients, and right and left septum in 11 patients with sequential unipolar radiofrequency, and right and left septum in 3 patients with bipolar radiofrequency after failed sequential unipolar radiofrequency application. The median follow-up in this study was 12 months, with a range to 3 to 47 months. And in this group of patients, 54%, so 14 total, remained free for recurrent atrial arrhythmias. I will conclude here that intra-atrial septal tachycardias, which include focal and flutters, are rare. 9% of atypical organized atrial tachycardia are flutters. Intra-atrial septal tachycardias do typically occur in patients with intra-atrial septal abnormalities, multiple ablation procedures or prior cardiac surgery involving the intra-atrial septum. Activation mapping and entrainment mapping are necessary for diagnosis, but entrainment is crucial to select the optimal ablation sites because all you can see with activation mapping is an early septal breakthrough with passive biatrial activation. Ablation of these flutters is quite challenging. A frequent need biatrial intra-atrial septal ablation, and occasionally you have to be prepared for bipolar radiofrequency ablation. Long-term outcomes, despite acute termination, seems to be suboptimal. It's typical and similar to what we've seen for intramural VTs. Thank you for your attention.
Thank you very much for the kind invitation to have the opportunity to discuss the percutaneous epicardial approach for atrial fibrillation and atrial flutter. These are my disclosures. So there's many reasons why we might fail with atrial fibrillation and atrial flutter recurrences. And we usually think about the absence of durable PV isolation. Those are really in 2 dimensions, saying there's a gap there. But it's very possible that some of these gaps are due to non-transmitter lesions, which are really 3D gaps. Non-PV triggers are possible, and obviously we're still in search for a unifying mechanism for atrial fibrillation. But the number one myth related to atrial fibrillation ablation is that the left atrium is a very thin-walled structure, and epi and endo are probably the same, and transmurality should be quite easy. And I think we're learning that that's simply not the case. Epicardial mapping allows direct access into the posterior wall via the oblique sinus, but note that you've got these pericardial reflections that don't allow free movement as there are as in the ventricle. In order to get to the anterior portion of it, you need to get anterior to the left-sided veins, over the ridge, and then over towards the Bachman region. This is the type of map that you can achieve with the percutaneous epicardial approach. And here you can see you can validate and assess the posterior wall on the epicardium. We do use the SOSA approach. This is the percutaneous puncture subxiphoid, and instead of using the anterior approach, the posterior approach is preferable because what you're trying to do is get to the oblique sinus and get the posterior left atrium. So that's really the best use of that. And this is not new. Young-Hoon Kim published this in 2007 with about 5 cases, and then Vivek Reddy showed the need to be able to ablate on the floor of the posterior box to be able to isolate the posterior wall in 2008. We started putting a series together between UCLA and U Chicago and published this last year, first author Ruhong Zhang. And what we did was we looked to see what the insights that we obtained from percutaneous epicardial mapping and assessed its feasibility. And here what you see is that sometimes you do get transmurality, as we would expect here in the RIPV, but then there's other times where you actually have relative epicardial sparing, which again represents like a 3D gap. So this is 94% of cases had reconnection in this redo series, but 17% had epicardial capture without endocardial capture, which is of interest. More importantly, when you look at the posterior wall, sometimes we see a whole grayed out area and there might be 1 or 2 spots, but we typically say, well, that's probably isolated. Well, here we have mapping of the posterior wall epi and endo, and you see that there's relative sparing on the epicardium relative to the endocardium. That's very insightful in the sense that sometimes we dismiss 1 or 2 areas and we think that, well, that probably is done. But here we actually did much more. We completed a box lesion just because of these 4 points that showed that there was relative sparing, but the knowledge that the epicardium was spared. And then we can then demonstrate that the posterior wall is isolated on the epi as well as the endo. 4 cases, 22%, demonstrated non-uniform transmurality in the posterior wall. And this perhaps was the most eye-opening of all of the experience, that here we've isolated the posterior wall. We have the Orion catheter on the endocardium, and we have another Orion catheter on the epicardium here. And what we see that during ongoing atrial fibrillation / flutter, you have variable block from the epicardium in AFib, this small region of viable tissue in the epicardium to the CS. And you also have variable conduction to the posterior wall represented by the Orion. So this is exactly what Alessi's been talking about, which is the epiendodispersion. They show that things go in and out and it's asynchronous. But here you have actually complete dissociated rhythms on the epi and endo. And that's some really nice direct evidence that we were able to obtain. Pierkowski has perhaps the largest series with 59 patients, permanence of PVI, and they started doing additional lines epicardially, and they actually found that 80% required epicardial ablation, and they actually were also able to see that there were LAVAs, or abnormal atrial signals, the LAVA equivalent, and 14% had isolated epicardial low voltage that's not seen on the endocardium. So getting to the other side does have utility. Now, perhaps the most relevance of the epicardium is really why we struggle with mitral flutter so much. So what are the barriers to some of these lines? Well, the inferior line, you have the coronary sinus. Superior lateral line, which is across from the appendage to the mitral annulus, you have to contend with the vein of Marshall. The anterior line, which is longer, but many people say thinner, does have to cross Bachman's bundle region. These are all epicardial structures. So no matter where you want to draw a line for the mitral flutter, you're going to have to cross one of these epicardial structures. So let's look at those quick highlights with each in depth. So the coronary sinus, you have a discontinuous pattern here. Sometimes this is confusing because you don't think of this as mitral flutter. There's an activation gap. We bring in the coronary sinus, which serves as an epicardial bridge, and that completes the whole circuit, where you have a line of block endocardially, it reemerges with a focal activation. That's very important here to be able to see and recognize. These are the reasons that we often have to ablate in the coronary sinus. So this here is a classical example of 3D bridging using the coronary sinus as an epicardial bridge. In some cases, you go to the epicardium because you've already ablated in the CS and you've done your mitral endocardially. And when you get to the epicardial side, which is still safe from the coronaries in the majority of cases, you can terminate atrial flutter, mitral flutter, in one burn. And in both cases that we had to do this, the first application terminated atrial flutter. So in this series, we actually had 45% freedom from recurrent atrial arrhythmias in a very difficult series when we went epicardially. Now, the mitral isthmus is a problem because the coronary sinus is a problem for the mitral isthmus line inferiorly for two reasons. Number one, you start getting towards thicker tissue as you get to the ventricular side of the annulus. But number two, the coronary sinus acts as a heat sink. And there's no better example as to Andre Davila trying to occlude the coronary sinus to be able to limit that heat sink and that cooling to be able to deliver better lesions. Now, then Feifa and Oyan comes along and says, well, let's not do that inferior line because of the coronary sinus. Let's do the supralateral line, just a little bit higher than that. And in a non-randomized study, they showed that it was faster and easier to get block with a supralateral line. So here's an example of a supralateral line from the top of the left common right at the bottom of the left atrial appendage. And what you see here is you've got mitral flutter that's ongoing. And what happens is it pops out right there at the star. And even though you've done a supralateral line, you can still have something that serves as an epicardial bridge. And when you look at the activation, the focal breakout is earlier in activation than it is back to the line, which defines an epicardial bridge. This is most likely the vein of Marshall. And here you can see with the correlative anatomy that you have these epicardial fibers that are running in the epicardial ridge. And then you also have this oblique vein of Marshall here. This is a beautiful image from Angel Cabrera. And this is really nice to be able to tell what is happening here. When we superimpose this, you could just imagine how the electricity and the impulse is being shunted over the epicardium and it drops back off into the endocardium. So the vein of Marshall is something to contend with, which is the second bridge. This would be an example of, again, mitral flutter activation with focal breakout at the top of the roof that comes back to this line. Here we have the same types of pattern where you have something that jumps beyond the line. You have to suspect epicardial bridging. And when we do epicardial access, we put a decapolar catheter in the epicardial ridge. And what you see here overlying the vein of Marshall is you have the continuous activation pattern. And here we actually do entrainment from that epicardial catheter, and we show perfect entrainment from the epicardium in this region. And this again is a highlights that this area is a perfect area that to create three-dimensional bridging. High resolution mapping after box isolation can show you that there's a little 2D gap. Something pops right through. So here's an example, which is very easy to see that and isolate the posterior wall. But sometimes what you have is you've got activation and then you've got a focal breakout in the middle of the posterior wall. And I think everyone has seen this and is frustrated by this. This is why Andrea Natali will just pepper in the entire box, because what we're trying to do is eliminate septal pulmonary bundle activation. This is an example of our first time seeing direct evidence of the epicardial activation. We've all seen this on the left, which is endocardial focal breakout. Endocardial focal breakout right there. But what happens on the epicardium when you look? Well, there are your septal pulmonary bundle fibers. They run down the posterior wall from the septum and the roof down to the floor. And then here we ghost in the epicardium, which is simultaneous. And what you see with pacing here down at the CS, you see complete preservation of the epicardial floor up to the posterior wall, and then the focal activation out. So this is really nice epi-endo dissociation, if you will, where the epi has more of the tracks of the septal pulmonary bundle, and then you've got a focal drop-off pattern on the endocardium. This is the first direct evidence that we had, and we've seen that in about 3 or 4 other cases. This would be the example of that with focal breakout. Another example where we're actually coming from the top down, and this is just during sinus rhythm pacing. We see that you've got focal breakout again, yet another example, and then the epicardium has entire activation with a little gap right at the dome of the left atrium coming the other way down the septal pulmonary bundle. So the last epicardial structure to discuss is what's responsible for this continuation of flutter when you do an anterior line. And this here, you have activation anterior to the SVC. You must be suspicious of Bachman's bundle because the activation goes from 1 to 2. This jumps across to the right atrium, back to the left atrium, creating a biatrial flutter. So this Bachman area is very important because as you cross from the mitral annulus to the RSPV, you will have to go through this thick portion right at the septum, bridging from the anterior to the SVC all the way to the vein of Marshall. It's a continuation where it actually splits into a Y anterior to the appendage and then down the ridge. This is a putative mitral line, and you can see what you're dealing with the transillumination. Bachman's region can be a barrier and serves as a 3D barrier there. So here would be the bridge. This is the activation. And again, this is how the anatomic correlation would be, that you've got these dedicated epicardial fibers that can then continue the signal across, even though the endocardium is blocked. A very nice series by Kitamura from the Bordeaux group showed 8 cases of Bachman's bundle bridging with biatrial flutters. And then in one case, we actually went directly to the epicardium, put the catheter from the oblique sinus back up over the ridge to get to the anterior portion here. So we're actually sampling right here over Bachman's region. And look at this bridging segment during a patient's mitral flutter that underwent 2 prior endocardial ablations. And you can see that beautiful electrogram over Bachman's region with entrainment that shows that the PPI equals TCL. And there's where we had termination of the flutter. So in conclusion, ladies and gentlemen, there are unique epicardial structures, but they are reproducible because anatomy is reproducible. And these really serve as barriers to creating transmural lesions. Think about epicardial bridging. Think about left atrial flutter in 3 dimension. And high resolution has given us the ability to be able to target some of these areas, knowing where the bridges are jumping out and where they're jumping back in. And in some cases that have multiple repeats, when someone has 3 or 4 prior ablations, we typically go epicardially at University of Chicago. Thank you very much for your attention and the kind invitation.
Hello, congratulations for all speakers, excellent presentations, and the best thing of this kind of organization with the pre-recorded videos, we have lots of time to discuss. I think people are already discussing on the chat, but now we have here all of you, and we can open the discussion, including the audience. And Andrea is ready. Are you ready, Andrea? No? If not, we ask to Roderick. Roderick, let's start behind. You have very nice image from the Picardo. I have to confess you, I did this kind of mapping many years ago when they start exploring the possibilities of Picardo mapping in VT, atrial fibrillation, and WPW. And I'm not too much. I'm not happy with the because I didn't find clearly how to use that for AFib ablation, because as we at that time we have lots of problems with the technology to make transmural lesions. But as the technology evolved, and with irrigated tip catheters, contact force, and everything, seems to me that we don't need to go to the Picardo. It's very rare. We need to go there to perform a transmural lesion in the left atrium. Instead, we want to have arteries or veins in the middle. So we have problems. So, but when we go to the Picardo, you have the same problem because the veins, the arteries are there. So that's I think Miguel has some space using the alcohol to make the lesions. So my question to you is: do you think that how frequent you think a Picardo exploration in patients with atrial fibrillation would be useful? Or you think the best thing exploring the Picardo or left right atrial is more for research? You think the research would be improved with this kind of information? And in which case you think we should recommend a Picardo access? Because the main problem is always the risk benefit. Because every time you make a pericardial puncture, you have risk, and this patient always, they use anticoagulation after. So there is a problem if you have an accident. I'd like you comment.
Sure. Well, I think your comments are very good in that, first of all, it's not for research, it's for patients that are desperate. So it's definitely more of compassionate use. And we typically will use it after someone has had at least 2 ablations, if not 3. We call them 3 DUs, 4 DUs, or 5 DUs. I think the yield is higher when someone has atrial flutter than fibrillation, because at least we know what we need to target something. And the typical example is, again, multiple mitral isthmus lines have been done, and you have to look at a map and see if it clearly has evidence of a discontinuous activation pattern. And I think you have to have already done 50 watts along that line, maybe with half normal or whatever adjunctive strategies you have. Now, I would say that we probably should be doing more of the venous alcohol, as Miguel has done, because that really might obviate the need to be able to do this. I do think that when you ablate in the epicardial ridge, anatomically it's a sulcus. So you can direct the catheter down in the epicardial ridge in the sulcus and do 40 or 50 watts and really isolate whatever you need to do. That's likely what's happening with Miguel's with the alcohol in the same area. So I think there's different ways to get to the same point. And you're right, probably globally, there's a lower risk to venous alcohol in the vein of Marshall than there is epicardial access for everybody. It's definitely not for research. It's for patients that have had multiple arrhythmias despite multiple ablations. And many times we will actually do the endo ourselves and do 50 watts over the area and fail before we reverse protamine and then we do epicardial. I think this is the most compelling to make sure that you know that you yourself have tried as well.
Great.
Mauricio, I have to add to what Roger said about the need to go epicardially. Just to remark that we changed our paradigm about ablation in the left atrium, because for years we were thinking that the thickness of the left atrium was enough to produce like transmural lesions every time, but it was not the truth, right? We were always thinking that in just in one, in an endocardial way. But at the end, in the left atrium, three-dimensionally, is as applicable as in the ventricle, even in the atrium. So I think the presence of epicardial, part of the circuit, so epicardial breaches and gaps explaining failed procedures is more frequently than we thought in the past, right? It doesn't mean that you have to go to the epicardium to deal with those arrhythmias, etc. But at least in our experience, in our prospectively collected experience, when isolating the posterior wall by box, we found that around 70% of the patients still can be captured from the middle of the box, despite of you eliminate endocardial EGMs and you prove absence of capture and 10 milliamperes and 2 milliseconds, meaning that you didn't produce a transmural effect. So it is very frequently, very frequent when dealing also with mitral line, very frequent when you are dealing with anterior lines, very frequent. So this is important to think and to remember that we have to think three-dimensionally. But I agree with you and Rod that maybe the need to go epicardially to ablate those gaps is not as frequent, right? Because we can ablate harder. Obviously, the esophagus is a problem in the posterior wall, but you can deviate the esophagus, etc. But if you don't think in that way, if you don't prove with the highest output that you can in the middle of the posterior wall, you will miss this information about the presence of epicardial bundles still present, etc. And you can have more recurrences. What is your opinion about it, Rod?
And the last thing I would add there is, this is man-made. This is because we often have non-transmural. So I don't think this is natural. If you only get one chance to do a good first pass treatment, but once you start adding fibrosis and ablation very superficially, what happens is, I believe, the second time you come back, it's much harder to burn through the fibrosis. And that's the challenge, is that all the biophysics that we know is through normal tissue. And this is not relevant in the first time. I think it's relevant after you've done it 3 or 4 times and someone still has flutter. Then you must think that there's probably something that's ongoing and you have a barrier to more effective delivery. Maybe electroporation will eliminate this. That's what we're hoping.
Yeah, sure.
Roderick, before changing the subject, I have to confess you that the last case we did, I think 2015, an epicardial mapping the atrial fibrillation, we got atrioesophageal fistula. So after that case, we decided to stop it until we have some kind of protection, maybe esophageal deviation. And now, reviewing your data, they are amazing. So we are thinking about coming back again, because when we start the place, we notice the epicardial ablation would be interesting, would be in the roof. Sometimes the roof, you are correct. We check, and then the endocardial, there was no potentials, but in the epicardial, we could clearly see the conduction in the roof. And one of the areas we can approach.
I think that's a great point, Mauricio, because we don't ablate from the epicardium because it's closer to the esophagus. We use the epicardial mapping to guide the endocardial ablation, kind of like Miguel published at UCLA, epicardial mapping of WPW, but it was used to guide endocardial. And you could say, well, why is that useful? But it actually can be useful, because sometimes you burn in an area you wouldn't burn on the septal pulmonary bundle because there's no electrogram, on the near field.
So we don't always start on the epicardial for burning, and I'm really glad you brought that up because that's not safe. In some cases, we have put the pericardial balloon, just like we move the phrenic nerve, to insulate if we're desperate. And in very rare cases, we burned epi if you really are sure the esophagus is not close by ice and by mapping.
So I want to make a comment because we have different experience, and I think you have to kind of look at every time you report data, you have to sort of pair them with the approach that you use. We actually recently did the 4 or 5 epicardial cases in patients with multiple procedures that were done by us, and in each single one of them there was no epicardial reconnection. It was about other trigger, CS for the most part, one for the appendage. So I think you need to kind of relate this epicardial sparing tissue to the approach. I think one of the differences, it could be the maximum power, the fact that people start low and ramp up. That's a problem because when you start low, before you get to high power, you might already have enough swelling that prevent you to go deeper. So we start always at, the setting 40, 45 watts, whatever we decide to ablate, but always high power. And we start at that setting. And also the duration of the lesion. The people that do 5 seconds, we actually have data showing that 5 seconds is not enough, even in the posterior wall, which is thinner. So imagine on the roof where you have thicker tissue. So there are a lot of variables that you have to apply to finding, and I don't think we need to generalize, but I think it's important to be aware of this, but I think we need to figure out what is responsible for that sort of lack of transmurality. Is the approach, the lesion duration. I think there are so many variables, it's difficult to generically say that, you need to sort of consider epicardial, because so far, I think the only case that we have seen some epicardial reconnection was an hypertrophic cardiomyopathy patient. and otherwise, we haven't seen anybody that had recurrence in the epicardium.
And I do want to just make sure that I'm clear that it's a higher yield for atrial flutter than it is for atrial fibrillation, because we don't know what we're looking for fibrillation. And if you have extra PV triggers, et cetera, you can do the SVC obviously without it. You can do the CS without it. You can do the septum without epicardial. So we're not looking for non-PV triggers. We're really looking to try to complete someone that's in persistent atrial flutter despite multiple ablations. I think that's where the yield is clear. But it's only after multiple, and Andrea is absolutely right. If you keep doing lesions that are non-transmural, you're going to get more of this. And if you minimize that, you'll see less of this.
I think if appendage isolation becomes established as a routine approach for recurrent or long-standing persistence, there are some cases where you ablate everywhere in the left atrium, the appendage still connected. I've done with venomartial alcohol. I know the mitral isthmus is ablated posteriorly, and in the roof there's nothing, and yet you pace the appendage, and sure enough, you get your upper crista in the right atrium conduction with sometimes 300 milliseconds delay, and there's nothing to map in the left atrium. And I'm sure those have Bachmann's bundles surviving fibers in the epicardium. I think for that approach, for that target, epicardial approach must be very useful.
But to be honest, we actually have seen that you have to be at the ostium of the appendage to isolate. This idea of the linear lesion is extremely time-consuming and as you mentioned, ineffective. The only person where I've seen that work easily is women, probably because they have a thinner wall, I think. But it's very difficult to isolate the appendage by making linear lesion, and you have to be at whereas the ostium with the target, with the circular mapping target, I think is much easier. So I think it's a technique also. So I'm not sure. I think the Bachmann bundle can become the last connection of the right to the left. So you isolate entirely the left atrium. So it doesn't matter if the appendage is isolated independently. You just isolate the entire left atrium. But to isolate the appendage, you need to be at the ostium most of the time.
Well, and also to tie it together, Andrea, you recently published with Luigi the LD band, the vein, which is what Miguel showed, which is the anterior vein, which is just ahead of it, may also go to the appendage. And you guys have shown that if you ablate more in the CS, sometimes you can get that as well.
Actually, Miguel was a co-author of that paper. Yeah.
Great.
Yeah, and when we talk about CS isolation, I think it was UPenn or Michigan that reported like discrete locations of CS connection with the left atrium, which I find it very interesting, but it's very impractical to look for those. And
I totally agree. Yeah.
Just ablate endo and then endocardial first and epi, like you mentioned. But my question was the dogma about CS intrinsic electrical activity is that the CS has a muscle sleeve from the CS ostium to the valve of Busson's, and beyond that, there's no CS intrinsic electrical activity. And I've written a review on that, and I show it in a figure. I think it's nonsense. I mean, many times I have ablated perimitral flutter. I give alcohol in the vein of Marshall. I have some residual CS, more annular conduction that's sustaining the flutter that will not go away with alcohol because it's annular to the balloon. And many times, I start ablating, making contact with the left atrium with the catheter bent upward, but many times I just deflect and I sample the electrical activity on the kind of free wall of the CS, and there's robust signals.
Yes, absolutely true.
It's time to get rid of that dogma.
Yes, it's true.
CS can have electrical activity all the way up there. Yeah.
I think there was somebody that was asking, when we do the appendage. I would say that for the most part, we do where the posterior wall of the pulmonary vein are silent. There is very little reconnection. The only group where we do it the first time aggressively is long-standing persistent with severe left atrial scarring. That's a group where we have good data that if you don't do that, and you have to do also the CS, those people are not going to be treated successfully. And if you think about it, most of those patients, the scar is in the posterior wall and around the pulmonary vein. So you're really dealing with somebody that start with trigger outside the pulmonary vein. You still have to clean up those areas. We still do. I don't know if it's going to change the success. But those are the only group where we clearly do it at the first time. Otherwise, we discuss this to the patient, even in the patient where we think is going to be important. We said, the first time we're going to give it a shot and not to isolate the appendage. Sometimes we delay because the appendage can take 2 procedures, but we don't isolate. And then obviously the second time usually becomes a target. So I don't want people to think we isolate the appendage up front in everybody because we don't. Most of the time we discuss that with the patient and we go through a sort of a step-wise approach.
One clinical pearl is that when you hear someone refers to you and they say they have mitral flutter, and they say we did anterior line and inferior line, if you go and map there and the appendage is not isolated, by definition, neither of the lines are done, or at least the one's not done. Yes. So anyone that says they've done 2 lines and the appendage is going, that's a really nice pearl for the fellows and things. It's not done. And that's really important. That's the proof of the isolation. The proof of the line of transmural is isolation of the appendage if you've had 2 lines.
Andrea, how do you avoid the phrenic nerve when ablating the left appendage?
Yeah, so the key is not, you don't want to go inside the appendage because the body of the appendage is very thin. So we put the lasso at the ostium, sometimes slightly in, and with the ablation catheter, we always stay in front of the circular catheter. So we use that as a marker. And if you do that, we never had any problem. I think we have one case where there was transient, and clearly we reviewed that the operator went way in beyond the lasso. Actually, no, it was a case where the operator did not use the lasso and it was way in the appendage. So the key is to use the circular mapping catheter, which help you to look at the recording, so you do less burning, but also help you not to go beyond the ostium area, which is where you take a chance of damaging the phrenic nerve. You have to be inside the appendage to do that.
Do you have always to go around the ostium, or do you think there are some segments like the veins?
Because there is a good number of patients.
It's a septal artery. Do you think that ablating that close the artery could do something?
We try to avoid. Also, consider we have always low contact. We move faster, so we should have the same key rule for the CS. One of the rules for the CS, it doesn't matter. Every 5 seconds you need to move, and the catheter needs to be kind of free floating. You never have to be wedged. So there are a few rules that prevent this type of problem, and one of them is moving fast. But there are clearly many patients where if you use the circular mapping catheter, you can really do segmental ablation to achieve the isolation. You don't have to do circumferential. Obviously, if you do it in fib, it becomes more difficult. That's why I advise people, when you're learning how to do it in sinus, because with the circular mapping catheter, you can position the catheter in a way that you can look at the activation and do more segmental rather than circumferential.
What about the left atrial occlusors? When you decide to insert the
yeah. With the old occluder, because of some of the issue, we kind of use it only for people that we thought were higher risk. And now with the new flex, we are encouraging everybody to actually do it. Usually I wait 4 or 5 months, and then we talk about doing that. And I always check. So another thing, even we do it in everybody, so we know the one that have low velocity, but we always check before we put the watchman, because once you put the watchman, if there is some reconnection and it's going to start giving problem later on, sometimes it starts to re-isolate. Certainly very difficult with the amulet because of the proximal disc completely block the access to the ostium. With the watchman, you can still do it in 80% of the patient, but there are people where you can't. So we always check before we deploy the watchman after an isolation, even when we know that the appendage velocity is low. One thing that I want to mention is that this is a common mistake. Even we're trying to publish that. I guess imaging people don't like electrophysiology to tell them they're making mistake in the way they read DTE. But we have very good place, very good academic place with dedicated imaging people that make a mistake the way they assess the velocity in the appendage. Sometimes these patients have big diastolic waveform, which are clearly passive. They are not after the P wave, they are in the middle of the diastole, and they are read as normal velocity. That's a mistake. That's a passive contraction from the ventricle. It's a mistake, and you should look at the velocity right after the P wave, between the P wave and the end of the QRS. That's where you look at the velocity. Everything beyond that is passive, it's not active contraction, and should be discarded. But we have a lot of patients that have stroke because they are TE, people tell you, oh, your appendage velocity is normal, you can stop the blood thinner. And when we review that, there were all these big diastolic waveform that are passive contraction, they're not active.
I have a question for Nino related with septal and intramural septal atrial flutters. Because I'm trying to understand the circuitry, right? The anatomy, based on anatomy. And it is supposed that the true septum is the foramen ovalis and the limbus, right? So maybe we have to understand that most of those septal flutters are at the end interatrial flutters, right? Using interatrial conduction waves, like Bachman, for example, coming back from the right to the left side, etc., through the coronary sinus connection to the left atrium. And it is difficult to think in just intramural septal atrial flutters, because that means that those are coming maybe from the limbus. So it is enough of space to have just a purely intramural septal atrial flutters. Nino, what do you think about?
So couple of things. I mean, when we review this data about septal flutters, most of them were posterior, nearly breakthrough to the fossa ovalis. So and that's the reason why we didn't map in most of them the non-coronary cusp, for example, which would be more anterior. We were far away on the intracardiac echo, so we didn't decide to do that. And if you look at the Waterston groove, you have a lot of interatrial connections there. There are not just the Bachman bundle, which is the most prominent one, of course, on the roof, and goes all the way to the appendage. And I think some of these really, they do involve this intra-atrial connection that we cannot map directly from the surface on the endocardium. We haven't done epicardial mapping, but I would assume it would be unmappable also from epicardial mapping, because if you go epicardial there, one of the limitations with mapping, which we haven't discussed, is the pericardial reflections. And it's an issue at the roof too, because sometimes you leave a big gap between the anterior part that you can map and the posterior part. And that's the reason why the convergent approach occasionally has got gaps at the roof line, because it just cannot get there. But the Waterston groove is really not accessible with a pericardial approach, because it's actually extra pericardial. It's in the fat pad, close to the pyramidal space. So I think some of it is that, but some other, when we say intramural, Unfortunately, with surface mapping, that means we don't know, it's not surface. So it's an indirect approach for us, right? So we map the surface, we don't find any good PPI, we find actually the closest to the circuit, we find an early septal breakthrough, and we assume that the tachycardia is somewhere in between. But without direct mapping, you're right. I mean, it's complicated to say exactly what it is. I don't think it's accessible, that area, not even with epicardial mapping.
Exactly. I mean, my point is that maybe we have to think that the missing part of the cycle length that we cannot collect during when mapping those septal flutters are placed on the epicardium. Those epicardial connections, etc., more than intramurally, right?
Yeah.
Do you think so?
Yes, I mean, between the right and the left, of course, if you stay away from the septum, that's the epicardium, right? There may be some epicardial connection there. And it's possible. I showed the anatomical picture that shows those disconnections in Waterston group. Those are epicardial. They go from the epicardial right atrium, septal wall, to the epicardial left atrium. But even if we go epicardial, though, we won't be able to map those, in my opinion. So, because we are far away from the where we can manipulate the catheters, because because of the oblique sinus stops at the pulmonary veins, and we cannot go beyond that.
Okay, and based on that, how to explain why bipolar ablation could be useful? Right? It is because you are, I don't know, focusing the radiofrequency energy in the epicardial, in the middle of both sides of the septum. Because obviously, if we are assuming that it's not real, it's not intramural, how to explain that? Right?
So yeah, that's a great point. So all of these cases had the substrate, and as Rob said, whenever you start having scar and low bipolar electrograms, etc. It may be more complicated to create a durable transmural lesion, like deep lesion with unipolar. The other aspect that we didn't discuss is that in that region, you can have these connections, but around the connection, there is a lot of pericardial fat around it. So I think part of it is that the bipolar will increase the ability of delivering lesion and eliminating these connections compared to unipolar. And I don't have a great explanation. The reason why we did bipolar is out of desperation in these flutters. In other words, we tried to ablate. We had slowing most of the times, but never we had termination. So we decided to go for bipolar as a rescue approach, and we were successful in 3. But one of these 3 patients actually came back with flutter again. So even if you have acute termination, that doesn't mean there will be long-term success. So, and I don't have a good explanation why bipolar is a difference. Is different than an intramural VT, for example, when there is muscle there. In that structure, may have muscle, part of it, might also have a lot of fat tissue sometimes, and there is fibrosis in between. Most of these people had surgery. One patient had atrial myxoma resection from the septum, some other ASD repair. So there is a lot of factors going on, I think, that would explain why probably bipolar may focus the energy more in that space as opposed to sequential unipolar.
Okay, thank you. I have a question for, can I ask something to Rod?
Yeah. I'd like to Pasquale. Pasquale, AV block is a very common complication when we are doing atrial fibrillation ablation. But it seems to me that when we are trying to make this kind of ablation on the septum for this septal flutters, we have some risk. Do you have any point about this? Do you have any experience with the AV block or something?
Yeah, this didn't happen, fortunately, in this case, in particular, in this series, but we have experience with, for example, patients that have prior right atrial surgery. Sometimes in order to get to the AV node, they have to go through the Bachmann bundle down to left atrial septum and then the access to the AV node. When we do a septal line there, so ablate the septum, sometimes you transect that only connection that they have to the AV node. And you end up with the sinus node being disconnected from the AV node. You end up with junctional rhythm. Basically, you pace the CS, you have one-to-one conduction, but the sinus node is dissociated from the AV node. We have seen that, actually. And these are cases where it's actually an intra-atrial block. It's really not an AV nodal block because we're far away from the AV node, but we're basically transecting the communication between the sinus node and the AV node. That we've seen that in a couple of cases prior. Again, this typically happens when you have a patient with prior right atrial surgery. So the right atrial free wall is already scarred. Patients with prior CPI is already blocked, and you do a septal line on the left atrial wall. And sometimes by doing these 3 things, you transect the communication between the sinus node and the AV node. And yeah, so when you put a pacemaker in this patient post-procedure, you have to be below the side of block. So we end up ablating. In one case, we put it inside the coronary sinus, for example, the atrial lead, because it was the only place where we can record signals and pace and capture and conduct to the AV node.
I have a couple of patients with that approach and with that problem of atrial nodal block, and we put them for a pacemaker, and my colleague was implanting the pacemaker, put the atrial lead in the atrial appendage, and he said, well, the patient is pacemaker dependent. There's no AV conduction. We had to go in and then put his lead right above the his in the right atrium, just immediately above the his. And you look at the chest X-ray, it looks like two leads like this, one for the atrium, one for the his. But yeah, it can happen, and there's no AV block, but there's functional, atrial nodal block situations like that.
Yeah. Andrea, when we are ablating the coronary sinus, don't be a little bit worried about the AV block also when we are in the ostium?
You have to monitor, yes, absolutely. You have to monitor, but as I said, monitoring, probably unless you have, if you're in fib, unless you have fast ventricular response, I usually prefer to do that in sinus and monitor the PR. But obviously you have to keep an eye on that, absolutely, yes. It's not common, but occasionally you have transient prolongation. You have to stop immediately. So you have to. It is something that you need to be aware of. Absolutely. Yeah.
Great. Miguel, I'd like to know what's your end point when we are doing your procedure, the Marshall organization.
So, Marshall alcohol. The endpoint is perimitral block. So you deliver the alcohol, you measure the scar endocardially, and someone was asking me how long it takes. It's almost immediate. By the time I'm done giving the alcohol, I do a map of the mitral isthmus. You will see the scar, and it's variable. And then typically what I do is I pace the appendage, monitoring CS conduction, and add additional radio frequency in the mitral isthmus along the alcohol-induced scar. And the goal is to get perimitral block. And in about 30% of the patients, you need to give CS ablation. And you would see it very, very obvious as you ablate endocardially after alcohol, you see that the local atrial activation endocardially is later than the CS distal. So you already have endocardial block, and there's just residual epicardial signal. That's an abstract we had in the last HRS. Basically when that happens, you stop endocardial ablation, go to the CS, and it's usually 1 or 2 ablations there, and then you have the perimitral block. I do recommend that when you give alcohol in the vein of Marshall, you complete the perimitral block, because otherwise you're going to have an incomplete mitral line, and that's not a good idea. Only very, very rarely does alcohol alone will give you perimitral block, because you have the CS, you have the space of the balloon, and then alcohol goes distal to the balloon, but there's an annular aspect of the mitral isthmus line that will not be done with alcohol. And that's about it.
I noticed that you infuse the alcohol very distal. Very distal. Don't you think that this proximal part of the Marshall vein could maintain
No, of course. No, we start very distal. I'm sorry that was not very clear. We start very distal, and that's where we give the first infusion. Then deflate, retract the balloon, inject alcohol again, up to 4 times. And the very last one is at the ostium of the Marshall. Many times the balloon is actually hanging in the CS. But yeah, we do it all along. The reason is when we started the first few cases, I did the first case in May 2008, first human. We would just give 2 injections from the proximal vein of Marshall, and I saw that there were cases with big vein of Marshall that I could not get scarred distal. So it makes sense from the standpoint that you're giving it in a vein, so you're fighting arterial flow. When you give alcohol in a vein, you need to overcome the flow to reach the tissue. So it's better to start distal, where you just have smaller capillaries and you're going to get to the tissue. and then come back more proximal. And then
have you seen any atrial tachycardia coming from the Marshall bundle?
So in the first series of patients that we did, we looked at patients that had failed a previous AFib ablation to see whether there were triggers in the vein of Marshall. And of course, you could criticize the method of unmasking triggers. We did, I think, isoproterenol at 10 for like 10 minutes, which may be not sufficient, but only in 2 patients out of 50, we saw atrial tachycardia coming from the vein of Marshall, from the ligament of, from that area. The vein is a vein, the vein is myocardium, but only
Great.
2 out of 50. I think Aman Chug from Michigan reported higher percentage, 15 or so. But I think his data was very inferential because he did not have a microelectrode. When I'm telling you that 2 out of 50, these were patients that had a Cardima catheter back when Cardima existed, a quadripolar catheter in the vein of Marshall with proven first activation in the vein of Marshall. When you don't have a catheter in there, it's all a bit inferential.
Miguel, I want to ask you, we had a case, I think you might have been in Austin because I was one of the cases where we did AP Live a few years ago, that after the ethanol, we went for the mitral valve, and in 2 lesions, we had an effusion without no very high contact. So is there a pattern of the ligament of Marshall that kind of make you worry about that, or this
no, I think, yeah, and I remember that case. That case, I don't think. In short, I don't know. I have not seen like alcohol making the tissue more friable or softer. Yeah. I don't think so. I remember that case because that patient had a second branch, like a bifurcated, like 2 vein of Marshalls, one that went very, very parallel to the annulus and that went to the bridge. And we cannulated selectively each of those. So the alcohol-induced scar was big, but I think, we might have torn the CS, which can happen, or during RF application, but I don't know. All I can tell you is I don't think alcohol makes the tissue more friable. I have not seen that.
Okay.
We have 1 or 2 minutes to close the session, so I invite you to make your final comments about your presentations, about the discussion. Start to you, Miguel.
So, well, listen, I think the goal for me today was to illustrate the procedural steps. I think I'm happy that this technique of Marshall alcohol is gaining some acceptance. I don't think it's a magic bullet for AFib. I don't think that exists. A magic bullet for AFib is impossible because the disease is too complex, particularly persistent AFib. But there are some scenarios, particularly perimitral flutter, after multiple ablations, where it can make a big difference, and I hope the message was conveyed. Thank you.
Great. Roderick, would you like to make a comment?
Yes, thank you everyone for the invitation. So these epicardial bridges are human-made, and that's important for everyone to understand that. But unfortunately, humans are the only people doing ablation right now. And until we can figure out how to get transmural lesions, like Andrea is saying, like if you do 20 watts with 5 grams of force everywhere, you're going to start seeing more epicardial bridges. That's very fact. But there are some areas that are very clearly associated with thicker regions, and that's why Miguel's doing the vein of Marshall. Everything ties in very nicely. And I think the septum is challenging, and I think Bachman's is hard. How many people get a first pass anterior line with block? How many people get a first pass box? That's the reason Andrea started doing peppering inside, because we know that it's hard to get transmural with a first pass. So if someone has a redo, it's most likely the pulmonary vein reconnection. But I think if someone has a 3-do, it's still most likely the pulmonary vein connection, unless it's cryo. But if someone has a 4-do, that's when we usually go. So I want people to understand there are risks, and we do not advocate this for everybody, but it's really for those that are desperate, that have had multiple attempts, and flutter has a much higher yield than fib. I don't know what we're looking for with fib.
Great, thank you. Pasquale?
Yeah, so first of all, thank you for the invite. I enjoyed the session and being here. So septal flutters, typically the way I approach it is whenever something doesn't make sense, usually it's coming from the septum, and that's the very first thing that we look at. The high density activation map works beautifully for a lot of flutters. It doesn't work well for this type of flutters, in my opinion, because all you see is an early septal breakthrough, but then you have to still use entrainment to understand where to deliver your energy. And then we call it flutters. I don't know what the mechanism is. I assume it's re-entering some of this, some others may be focal. There is no way for me to tell really. They look focal from a surface mapping, but we don't know. And how to apply energy, of course, we always try with unipolar first to the shortest PPI, the best that we have in the area of early breakthrough. We go to the other side, like we do for VT ablation occasionally, and rarely you have to be prepared for something more, including bipolar ablation. That's it.
Great, thank you. Andrea, would like to make the final comments and close the session?
Yeah, so I think, great presentation. I think all this presentation give a clue to operator to think beyond the box. It's not, especially when you have a redo where the pulmonary vein have been taken care of. So think about different option. And I think all of this presentation give you sort of an alternative strategy to address different situations. I think we need to have an open mind when we deal with this patient, especially when you're dealing with people that come to you after 2 or 3 previous procedures. So I hope everybody enjoy. It was a pleasure to be part of this session, and we'll hope to see you soon.
Great.
Thank you.
Thank you very much.
Well,
Thank you.
Mauricio, we want to invite the tendency to see the next session. We will have a break, 10 minutes break, to start the final part of the academic program for today, and that is the transmission of a live case from Grandview Medical Center to show a high standardized workflow for catheter ablation and after fibrillation to decrease operation times. So thank you very much for all the speakers that were part of the model, for the panelists, the chairmen. It was great discussion, and I think we learned a lot. Thank you, and see you in the next session.
Bye.
Thank you. Bye-bye.
Bye.